Savita.
Good evening, everyone. Myself Savita, studying final year from KPV Government Medical College, Trichy. Today I am going to present the brief presentation of Preterm. Baby of Mrs. Reshma Beham, 4 days old female, born to a 22-year-old primary mother of non-consanguineous marriage, hailing from Trichy, admitted for low birth weight tag. Informed his mother, whose reliability is fair. History of presenting illness. Baby was born on 23/10/2020 at 5:39 a.m. by LSCS at MGMGS Trichy. Tried immediately after birth. Meconium and urine passed within 24 hours. Mother's LMP was on 16/4/2020, EDD on 23/1/2021. The baby was low birth weight of 1,650 grams, was admitted at birth in NICU for past 4 days. Baby was fed with expressed breast milk on day 1 and 2 of birth, when the baby was started with direct breastfeeding. No history of presenting respiratory distress, no history of yellowish discoloration of eyes, no history of feed intolerance like abdominal distension, vomiting, no history of blood in stools, no history of delayed passage of meconium, no history of hypothermia, no history of fever, no history of seizures, no history of irritability, no history of decreased activity. Maternal and antenatal history.
Savita,
Yes, sir. Yes.
can you go back to the first slide? Yeah, previous one. Yeah.
Yes, sir.
Next. Yeah. So, what is basic questions? What is a normal time by which you expect urine and meconium to be passed in a normal newborn?
In normal newborn, meconium should be passed within 24 hours, and urine within 48 hours.
Okay. So this baby is a preterm baby or a LBW baby. It's a preterm as per LMP and EDD.
Sorry, yes, sir. It's a late preterm baby. Sir.
Okay, late preterm baby. Okay, proceed. Okay, in this slide, previous one. So why did you ask for history of respiratory distress?
Because the baby is the preterm, so I should rule out that.
Sorry, your background is very noisy. I think you check it. Okay.
Savita's.
Your background, is lot of noise is coming.
Dr. Savita, can you try a different earphone, ma'am? Or a headphone? Or can you try without the earphone as well?
No. Hello, ma'am.
Yeah.
Hello, sir.
Okay. Audible, ma. But background noise is there. You continue. A bit louder.
Yes, sir. Since the baby is a preterm baby, so I should have to rule out if there is any associated preterm associations, if there is any complication associated with preterms.
So what is the cause of, what could be the cause of respiratory distress in this baby?
So there is any respiratory distress syndrome like hyaline membrane disease.
Okay. Why did you expect feed intolerance?
Savita.
Savita, you're muted. You're muted, ma'am. Can you unmute?
Hello, sir.
Yeah, don't mute. Okay, you unmute. Keep unmute.
So why did you expect feed intolerance in this baby?
So since the baby is preterm, so I should have to rule out there is any neonatal necrotizing enterocolitis or neonatal sepsis is present.
Okay. Before that, accepted. These two points are accepted. Any other reasons for feed intolerance? Difficulty in feeding, something like that?
So if the swallowing reflex not well developed means.
Well developed or the coordination between.
The coordination.
Yeah.
So
what is the cord?
So routine sucking and swallowing reflex.
Actually, what is the time at which gestation age at which you expect the sucking, swallowing, and the breathing coordination to be established and fully mature?
So around 35 to 36 weeks.
Actually, the sucking, swallowing coordination is established at 34 weeks, and along with breathing, it's fully matured at 37 weeks. Fully matured. But any baby born at 34 weeks completed gestation age can be given direct breastfeeding. So usually they won't have feeding difficulties. So any baby born below 34 just completed gestation weeks will likely to have feeding disturbances. Okay. For that purpose alone, we need to admit. Without any other complaints also, we need to admit the baby in NICU and observe for feeding. Okay. Okay. Why did you ask for history of blood in stools?
So, to rule out a necrotizing enterocolitis, that indicates any gut immaturity, sir.
Okay. So how did you ask for no history of hypothermia or told? So how did you ask the mother?
Sir, but whenever the mother is placing the hand over the abdomen, is there is over the feet, sir? I mean, over the extremities, is there is any temperature variation is present or not?
Okay. So which part of the hand will be used when you clinically examine the baby? Which part of the hand?
Dorsum of the hand. Is,
Okay, that's good. How will you assess clinically assess hypothermia using the dorsum of your hand? So if a normal baby, it should be warm throughout. So in mild hypothermia, mild to moderate hypothermia, the core, that's the abdomen will be warm and the extremities will be cold.
cold.
In severe hypothermia, the core, that's the abdomen will also be cold to touch.
Cold. Yes, sir.
Okay. So why did you ask for history of seizures, irritability, and decreased activity? Seizures could be due.
Due to any metabolic complications associated with prematurity, so like hypoglycemia, hypocalcemia.
Okay.
Or any birth asphyxia.
Okay. Then any other cause accepted? All your answers are accepted. Any other things? Could be sepsis.
Sepsis also, yes, sir.
Could be sepsis also. Okay. Proceed. Sendil, Dr. Sendil, any questions?
Yes. Savita?
Yes, sir.
Don't worry, be cool, okay?
Oh,
Nothing.
okay, sir.
You are a final year student, okay?
Yes,
Need
sir.
not know
Yes, sir.
everything, don't worry, ma. Okay?
Okay,
First
sir.
of all, how did you arrive that this is a preterm?
Sir, by asking that LMP and EDD, sir.
Okay. Then how will you calculate EDD for a baby? How will you, sorry, it's not EDD, gestational age, how will you know? This baby, how will you know this much weeks this baby is? How do you know that?
So by applying Nigel's formula, sir.
What formula? Illapa, you have
Yes,
now
sir.
you know the EDD.
Yes,
Let
sir.
us take a baby is born on EDD.
Yes,
What
sir.
would be the gestation of the baby?
So around 40 weeks, sir. 30.
Yeah. See, the period of gestation, that is period of intrauterine life is 280 days. This is
sir.
what we calculate. From the LMP, we add 280 days and we come to a EDD. Okay?
Yes, sir.
Okay?
Yes, sir.
Right. If the baby is born on EDD, it would be 40 weeks. Okay?
Yes,
Let me
sir.
tell you one example. If the baby is born 21 days before date EDD, expected date of delivery, then what would be the gestation of your baby? 21 days before expected date. How many weeks?
So 3 weeks, sir.
Then it would be 37 completed
37
weeks.
weeks.
Am I right?
Completed weeks. Yes, sir.
Yeah. This is how. In this baby's EDD is?
Sir, 23/1/2021.
Yeah. The baby was born on?
Sir, 4 weeks prior.
No. Just you. Baby was born on 23/12. Am I right?
12. Yes, sir.
Yeah. 1 month before. That in the sense, January 23 days and here 8 days. 23 plus 8 is equal to?
Sir,
31
days. Yes,
31 days. 4 weeks, 3 days. So what would be the gestation of this baby? 35 weeks, 4 days. Okay?
4 days of this, sir.
Are you okay? Is it satisfied? 35 weeks, 4 days. Right. This is how we calculate gestation of a baby. Okay? Just by counting this number. But this EDD, which is, this is very accurate when that particular parents is having first trimester ultrasound record. More reliable than your last menstrual period EDD. Okay? Whenever they have first trimester ultrasound, take that EDD as a priority. Okay? From the TDD, you can calculate a gestation of any baby. Okay, ma?
Okay, sir.
Fine?
Yes, sir.
No doubt about that?
No, sir.
Okay. Okay, you called it as a preterm. You even labeled it as late preterm. How come? What is late preterm then?
Sir, from 34 to 36 plus 6 days of 36 weeks plus 6 days of gestation.
Fantastic, ma. Exactly. Fantastic. Good. Why, ma? Why they want to differentiate? Why they want to keep a feather over that preterm? Why?
Because the feeding pattern will vary, sir.
Just now, Sarah has explained, no?
Yes, sir. Around 34 weeks only the sucking rooting reflex will be present, sir. At 37 weeks only it will be fully completely mature. Yes.
Fantastic, ma. You have become a neonatologist now. Very good. Yes, actually, though these babies are preterm, they can live on their own if you give a mild support. That's what it means. So they label it as late preterm. Fantastic. Okay, your presentation is very nice. Go ahead. Go ahead.
So, maternal and antenatal history. Age at marriage at 22 years. Mother had regular cycles of 32 days with bleeding for 5 days. Conceived within 2 months of marriage by spontaneous conception. Mother's blood group B positive. Pregnancy confirmed by urine pregnancy test at 6th week of amenorrhea at PHC Varayu. LMP 16/4/2020. EDD 23/1/2021.
Savita, one question. Savita, one question. Back.
Yes,
Yeah. So you told that the mother conceived within 2 months of marriage by spontaneous conception. Okay, accepted.
Yes,
Suppose, let us take a different example. Suppose if a mother conceives after treatment for a long period of infertility, so what are all the risk factors that could be there? So there they will be giving ovulation inducing drugs, yeah?
Yes, sir, like clomiphene citrate.
Yeah, okay. So what are all the risks that can be associated?
It will lead to small for gestational age baby.
Only small for gestation age baby, yeah?
So low birth weight.
Low birth weight can a reason. What could be the reason for multiple pregnancy? Yeah, good.
Fantastic. Good.
Multiple pregnancy. Okay, continue.
Registered and immunized with 2 doses of TD. Pre-pregnancy weight 55 kg. Weight gain during pregnancy 8 kg. Number of antenatal visits 7. Iron folic acid tablets taken. 2 antenatal scan taken.
This is during the first trimester, or through the entire pregnancy? This is entire pregnancy.
Yes,
what is the normal weight gain you expect during the pregnancy?
Around 10 to 12 kgs.
Okay. How many antenatal visits should be there mandatorily?
Sir, minimum at least 5 antenatal visits should be there, sir, but ideally 13 antenatal visits.
13 antenatal visits when?
Sir, for yes, sir. So up to 7 months, each month 1 antenatal visit, sir. In 8th month, for 2 weeks once, sir. In 9th month, weekly once, sir.
Okay, good. Okay, continue.
First trimester, USD dating scandal, EDD confirmed, folic acid tablet taken irregularly, no history of hyperemesis gravidarum, no history of fever with rash and lymphadenopathy, no history of radiation exposure, no history of other drug intake, no history of bleeding or spotting for vaginum.
Okay, ma'am.
Okay.
Yes, sir.
You asked.
Yeah. Savita,
Yes,
no history of hyperemesis gravidarum. Are you worried about fetus when the mother is having hyperemesis? Does it have any significant fetal outcome?
Yes, sir, definitely, sir.
What do you think?
So the mother is continuously vomiting, sir. The mother definitely will have the nutrition supply to the fetus at the particular period of time will be low, sir.
Okay. That's what we think, ma. Actually, hyperemesis gravidarum has nothing to do with the fetal outcomes. That is the truth. Until otherwise, it causes mother's hospitalization. It used to cause mother's hospitalization. Until otherwise, hyperemesis gravidarum have no role in fetal outcome. Okay. But anyway, when the hyperemesis gravidarum is too abnormal for the mother to get admitted in the antenatal ward, then it may be a worrisome thing. Okay. Then second
Okay,
question,
sir.
fever with rash and lymph nodes. Why are you worried about this thing, ma?
Because the baby is preterm baby, sir. If there is any
No, first
torch
we are not
infection,
worried about. Yes, fantastic. Torch. I don't know
torch
what is torch.
infection,
What do you mean by torch, ma?
toxoplasmosis, rubella, cytomegalovirus,
Okay.
herpes hepatitis, then others like syphilis. Now they include Zika virus also, sir.
Main, one more culprit. Others, one more culprit you forgot. Main culprit. Start with the H.
HIV, sir.
HIV, sir.
Good. Very good. Okay. All these may cause intrauterine infection. Even that may induce preterm labor. So you are more worried about that. Fantastic. Good.
So any other viral infections can be there that could have an adverse effect over the infant or the newborn
So varicella.
or over the fetus. Chicken pox, varicella. Good. Okay.
The
Any
other
other
students
infections?
also can answer. Sir, encourage the other students
Yes, ma'am. Yes,
also.
ma'am. Yes,
Yes, sir. Will do it. Yes, madam. Yes, madam.
If the mother has rubella fever in the first week, how the baby will be affected? Renuga,
Abortion, ma'am.
when? What else? If baby is delivered means, what are all the things you have, in what way it will be affected? Baby born to a mother.
Patent ductus arteriosus.
That is called, the syndrome is called congenital
rubella syndrome.
Good.
What is the classical triad?
Cataract, sensory neural hearing deafness, coarctation of patent ductus arteriosus.
Three. One is
Patent
hot
ductus.
disease.
Patent ductus.
Okay, ma'am.
It's a cataract.
Renuga should answer.
Renuga?
Sir, congenital cataract, sensorineural deafness, and patent ductus arteriosus.
Okay, fantastic, ma. This completes the triad. Good.
Okay.
Good. Okay.
So, okay, continue. Any other questions, sir? Dr. Sandhil, any other questions?
Ma, what radiation exposure you are worried? Why are you worried about radiation exposure, ma?
If it is more than 5 millirats, means it will cause, because in the first trimester only the embryogenesis, organogenesis will be
Very good. Okay. Within 8 weeks, it's a high phase. In this phase, if the mother gets radiation, at that too more than 5 rats, they are more prone to get anomalies. Am I right?
Yes, sir.
So that may even cause prematurity. That's why we are worried about radiation exposure in this case. Why are you worried about bleeding or spotting, ma? Just try something.
Any abortions, sir?
Yeah, that's what. Yes.
Abortions.
Yeah, missed abortion, any missed abortion, or this may be a sign that the baby had any placental involvement. Any placental involvement may cause the baby to get delivered prematurely. That's why we are worried about bleeding and spotting per vaginum. Okay? Clear?
Yes, sir.
Shall we move? Yeah.
Yes,
So
sir.
one more question.
Yes, sir.
Pratibha, in this slide, folic acid tablets taken irregularly. That was what mentioned here. So
Yes.
do we routinely prescribe folic acid tablets to all the mothers in our antenatal clinic?
Yes, it is prescribed for 160 days of. For 160 days, it is recommended to be taken of gestation.
Folic acid tablets. And I am asking about folic acid, not iron and folic acid. I'm asking about folic acid tablets.
So folic acid tablets are usually started from second trimester, and
No. I think that you are getting confused. Iron and folic acid tablets are different. And in this slide, she has specifically mentioned folic acid tablets taken irregularly.
Yes, sir.
Okay. So is there any...
Sir, she is confused on the iron folic acid. Pa, how folic acid is given to the mother, pa, in the antenatal period?
Savita, unmute.
So ideally, it should be taken periconceptually, sir.
No, ma. How
Yes, sir.
ma, routine as a routine in the antenatal period? How folic acid is given to the mother, antenatal mother, along with something, or we give separately?
We give separately, sir.
As per our national program, okay, we give folic acid. No, folic acid along with iron, right? Okay.
Yes,
In
sir.
what instant, if you want to give, you have told periconceptional. You used the word periconceptional. So, in
Sir.
what condition we give folic acid alone to antenatal mother
Sir, if there is
before
any
getting
previous,
pregnant? Yeah,
yes, sir. So previous history of birth history of any neural tube defects.
fantastic.
The
Great.
baby
Good.
born with
Okay. This is what the evidence says. Almost, if we give periconceptual folic acid, that is 3 months pre-conception and almost 1 month later after. If you give 4 milligram of folic acid, it reduces 60%, almost 2/3 of neural tube defects can be reduced, even if the baby had first baby with neural tube defects. Okay. Even if the mother takes too much folic acid, does it have any harm? Is it a water soluble vitamin or
so water soluble vitamins.
so is it a harm? It shouldn't be. Okay, it should get excreted. Okay.
Yes, sir.
Any other advantage of folic acid tablets? Suppose some physician has prescribed during the first trimester, because this is a primary mother. So why they would have prescribed?
It decreases
Nutritional
the preterm.
Decreases?
It's the
Nutritional
preterm.
Savita?
Yes, sir. So it decreases the preterm birth, sir, and also it prevents congenital heart disease also. Sir.
Okay. There were some studies to indicate these points, and it generally improves the outcome of the pregnancy. There were some studies. Okay.
In antenatal period, nutritional anemia, that too, isolated anemia, isolated iron in the antenatal period alone cannot cure all the nutritional anemia in India. So it should be given along with folic acid to reduce nutritional anemia, because in women's, that too in women's in the antenatal period, most common cause of nutritional anemia is deficiency of both iron and folic acid. That's why our recommendation is to give iron and folic acid hand to hand, except in exceptional scenarios. Okay. We'll move to next slide.
Second trimester, an anomaly scan was done at 20 weeks of gestation and no obvious anomalies were detected. Quickening felt at 20 weeks of gestation. Iron and folic acids were taken regularly along with calcium. No history of gestational diabetes mellitus. No history of headache, blurring of vision, epigastric pain or pedal edema. No history of bleeding for vaginum.
So why did you ask for it? Why did you ask, madam?
No, yes.
Savita, why did you ask for history of headache, blurring of vision, epigastric pain, or pedal edema?
So to rule any pregnancy-induced hypertension, sir, to rule out
Okay.
pregnancy.
So otherwise, you could have asked straight away that whether the mother had any increased BP. So that could also be there. Okay, accepted.
Yes. Madam, anything else, madam?
Yes, ma'am.
Name some neural tube defects that can be detected through ultrasound. Neural tube defects.
Yes, ma'am. Like spina bifida.
More than that, more complicated than that. Anencephaly.
Yes, ma'am. Anencephaly.
There will be a mass in the lumbosacral region. Remember?
Yes, the meningomyelus.
Fantastic. Good.
Okay, suppose because you didn't mention in the first trimester, suppose an ultrasound was done in the first trimester of pregnancy, what could have been looked for in that first trimester ultrasound?
Crown heel length.
Yes, crown drum length. Along with that, some abnormality. Sari is asking for some abnormality.
Nuchal translucence.
Fantastic.
Yeah, good. Okay. So what is that for?
To note any chromosomal abnormalities
Very
like
good. Chromosomal.
Very good. Okay.
Very good, ma. Very good.
Okay. Proceed.
So third trimester, iron and folic acid tablets taken along with calcium. Growth scan was not taken. No history of burning micturition. No history of bleeding per vaginum. No history of foul smelling discharge. She was diagnosed with pregnancy-induced hypertension during the last antenatal visit at PHC. She was referred to MGFGH Trichy immediately.
Okay. Madam, any questions, madam? Here, Dr. Sendil.
Yes, sir. Yes. Sir, we will allow her to speak, sir. Then we will ask. Yes, sir.
Okay.
Perinatal history, single dose of intramuscular injection administered at the time of admission, said to be for augmentation of lung maturity. A preterm live baby girl of birth weight 1650 gram was delivered by LSCS at 5:39 a.m. on 23rd December 2020. Indication for gestational hypertension.
Renuka, you are
Yes,
there?
sir. Yes, sir.
Intramuscular dose of antenatal steroids, something as mentioned, right?
Yes, sir.
Intramuscular injection. Yes?
Yes, sir.
What intramuscular injection you are suspecting, ma?
So it's dexamethasone, sir.
Okay. What for they are giving dexamethasone?
So it is given to improve the lung maturity, sir. Lung surfactant and
Surfactant deficiency.
deficiency.
Yeah.
And it's
Okay.
removed.
Anything else? Any other uses, ma?
And it prevents intraventricular hemorrhage, sir, and
Good.
then it decreases the infant mortality, perinatal
Okay.
mortality, and it prevents necrotizing enterocolitis. So
Okay. Okay.
then
So what is the
Very good.
dose? What is the
it's
dose?
6 mg, sir. 6 mg per kg, 4 doses,
6
12
mg
hourly.
per 6 mg per kg illa.
Per kg illapa 6
6 mg.
6 mg. How many doses, ma?
Hello.
4 doses.
4 doses, sir.
Just
12.
12 hours
doses.
apart.
Very
12
good.
hours
That's
apart.
it. That's it. You have given the right answer. Good.
Okay.
In
So-
what babies? In which antenatal mothers this has to be given?
Less than 34 weeks and gestational period.
Okay.
Mm.
So can you name one contraindication for antenatal steroids?
In case of chorea, absolute contraindication in case of chorea amniotis.
Good. Okay.
Very good. Forward chorea amnitis. Okay. Otherwise, there is no other contraindication. Previously, now it is the evidence is 24 weeks of gestation to 34 weeks of gestation. Any mother in emergency labor lands up in emergency labor, you are supposed to give dexamethasone. The alternative drug is betamethasone, but now the drug of choice is dexamethasone. No doubt about that. Okay. Okay. Right. Good. Now the baby is preterm, live baby girl. I would like to ask you this question. What is the gestation now? You told first trimester dating scan done, EDD confirmed. Now you should know the gestation of your baby. No, what is your gestation of the baby?
So 35 weeks and 4 days.
30.
So 35 weeks and 4 days of.
35 weeks and 4 days. Is it okay? Antenatal steroids. Up to you. Just now you have mentioned indication is less than 34 weeks.
34
Is it
weeks
okay?
is.
Okay. So there is a gray area, but you need not worry about that. As an undergraduate, you should know that antenatal steroids are given between 24 to 34 weeks of
34 weeks.
gestation in emergency situation. Except in elective conditions, we give up to 38 plus weeks, 38 6/7. That is okay. But as an undergraduate, you should know 24 to 34 weeks. Okay. Okay, move ahead, ma.
So immunization history, no vaccines given. Family history, no history suggestive of preterm delivery in family.
What
Okay.
family member whom you will ask?
So a mother, then grandmothers. Then mothers.
Mother-ஓட sisters இருக்காங்கல்ல,
Sisters,
mother-ஓட
yes,
elder
mother's
sister,
sisters.
even mother may be a preterm girl. Okay.
Yes, sir.
Family history. Why in family history, in what way it causes preterm? When there is, let us take, then there is a positive family history. What would be the problem in the mother?
Sir, like
To deliver
genetic
it.
composition, like cervical incompetence. I mean, sorry, pelvic incompetence.
Very good. Cervical incompetence, that is short cervix, will run in families that may result in cervical incompetence and premature delivery. Okay, good. Go ahead.
So socioeconomic history, the family belongs to upper lower socioeconomic class according to modified Kupuswamy scale. Then summary, a preterm female baby born out of non-consanguineous marriage at 35 weeks plus 4 days of gestation of birth weight 1650 gram by LSCS with significant antepartum issue of pregnancy-induced hypertension. Baby is probably small for gestational age with no preterm complication.
Pratibha, are you there?
Yes, sir. Yes, sir.
How will you classify newborn babies based on the weight?
So low birth, less than 1.5 kg will be extremely low birth weight. Less than 2 kgs will be low birth weight.
No. I don't think that.
Less than 2.5 kg low birth weight. Sir.
Okay.
Very low birth weight, less than 1.5 kg. Extremely low birth weight baby, less than 1 kg. Incredibly low birth weight, less than 750 grams. Sir.
Okay. So according to gestational age,
so
previously you told.
Yes, sir. So this is irrespective of gestational age, sir.
Okay. I am asking, then how will you classify according to gestation age? So that's what your topic is, right?
Yes, sir.
Term, preterm.
So preterm, term, and post-term.
Okay. Based on the gestation age.
So we're plotting the baby's weight on the Fenton's charts, sir.
That is including birth weight and gestation age. I am asking
Gestation
only
age, yes,
gestation age.
Yes.
So now she told, Renuka told, I think. Renuka, can you describe the ages, gestation age? Term, post-term, you told,
sir.
Renuka, you told, term, post-term. So,
Yes,
so based
sir,
what gestation age?
37 to 42 completed weeks is term, sir, and more than 44 weeks is post-term, sir.
More
And
than
below
44,
42 weeks.
42 completed
okay.
weeks, sir.
Okay.
Then below 37 weeks is preterm, sir.
Okay. So preterm classification, I think already
Sir,
you are told.
Yes, sir.
Okay.
Less than 28
So,
weeks is extremely preterm, and
Okay.
28 to 33 is moderate preterm, and
33 or 30?
34.
33, 6 by 7. 6 by 7.
Okay. Okay.
then 34 to 36
6 by 7.
6
Less than
plus
37
6,
weeks.
yes, sir, plus 6 days is late preterm, sir.
Okay. Madam, any questions, madam?
No, sir. Let us proceed.
Okay.
Okay, ma. Sir, only one question, sir. From this
Yes.
summary, have you made out what is the cause of this preterm for this baby?
Yes, sir.
What is the cause?
Most probably there is any eclampsia, severe pre-eclampsia.
Yes. The problem is mostly the cause for this prematurity is iatrogenic. Am I right?
Yes, sir.
Mother has developed pregnancy-induced hypertension. To safeguard the mother, the baby has been delivered. Am I right?
Yes, sir.
So the cause is iatrogenic secondary to PAH in the mother. Good. Okay. Tell me.
Other than PAH, what are the other causes for preterm labor? Maternal causes.
Ma'am,
Renuka.
yes, ma'am. Multiple gestation, ma'am, and maternal
Yes.
malnutrition.
Yes.
Then maternal malnutrition, multiple gestation, and torch infections. Then placental factors like placenta previa, abruptio placenta, and placental insufficiency. Then uterine causes like uterine anomalies like biconate uterus, uniconate,
Yes.
then septate uterus, and cervical incompetence.
Any other fetal factors?
Fetal anomalous babies, ma'am. Anomalous babies, ABO incompatibility.
Congenital malfunction.
So
Okay.
you told Renuka, you told about maternal malnutrition. Any other conditions in mother?
Sir, urinary tract infections, sir.
Okay. Any other thing that could have worsened during the second trimester of pregnancy?
Preeclampsia.
Like any pre-existing illness in the mother
Yes, sir.
before conception itself that could have worsened during the second
Diabetes.
trimester. Okay, one accepted. Maternal diabetes, pre-existing diabetes. Okay, then
So
any
any
chronic,
heart disease.
any heart disease. Good. Any what commonly we see rheumatic heart disease or any other congenital heart disease also. Any heart disease that could have worsened during the second trimester of pregnancy, leading on to congestive cardiac failure in the mother, can also have an impact over the infant. Okay, fetus. Okay. Or any chronic respiratory illness or
No,
any
asthma, sir.
asthma,
Bronchial
any
asthma.
chronic reactivation of tuberculosis, all those things can have an impact over the fetus. Okay.
Very good that Renuka has classified very nicely, right? Placental causes, uterine causes, cervical causes, then maternal systemic diseases, then fetal cause. Fantastic. This is how, if you classify, even if you tell two causes of under each subheading, it would be a big, it's like a big essay. So try to learn like this, to classify and read. Okay, good. Proceed.
General examination, postural limbs flex, baby sleeping comfortably, easily arousable, appears fit, no pallor, no icterus, no cyanosis, no edema. Vitals, heart rate 130 per minute, respiratory rate 45 per minute, axillary temperature 36.9 degrees Celsius, capillary refill time less than 3 seconds, oxygen saturation 98% in all 4 limbs.
Okay. Capillary refill time, where will you look for? Pratibha?
So we'll look on the sternum. So we'll place 2 fingers on the sternum and for 3 seconds, and we'll remove it and we'll see.
5 seconds. You told correctly, and
5
then you have changed 5 seconds. 5
5
seconds. 5 seconds.
And
And then you
it
remove, and then you count. And
Yes.
it should refill within 3 seconds.
less than 3 seconds. Yes, sir.
Okay. So one
The
more
pulse
thing.
oximetry reading is 90%. What do you mean by pulse oximetry screening?
It is done around 24 to 48 hours, ma'am. The pulse oximetry screen, that is partial pressure of oxygen, is recorded in both the upper limbs and either of the lower limbs, ma'am. If the difference is more than 3, it is significance of critical congenital heart disease. Partial pressure of oxygen.
No.
Just the
Saturation.
oxygen value. Just the saturation
Oxygen
value.
Saturation.
Where you have to record?
It's both the upper limbs and either of the lower limbs, ma'am. Any of the 2 lower limbs, either right or left, can be recorded, ma'am.
Then
Upper limb, which
upper limb,
specifically?
which limb is preferred?
Right
upper
lip.
lip.
Right.
Yes.
Right upper limb. Okay, that's good.
Then Renuka, continue. Why it is done? Pulse oximetry screening, when it is called abnormal.
If the upper limb and lower limb is the difference is more than 3%, means it's significant.
Anything else? You need to add something else?
One more thing.
Significance.
Acrocyanosis will be there.
No. Pulse oximetry. Saturation allowed.
It's a sign of critical congenital heart disease.
Good.
Yes.
But that is the inference, ma. But what is the number? 90, some 5, something else? You remember?
So less than 90,
Yes.
94%. Sir.
90?
I think
90 to 95%.
No, it's not 90, ma. More than
94.
95. See. Let me tell you. It has to be done preferably after 24 hours of life in any newborn, and the predictal, that is right hand, that is taken always as predictal. Okay. Any of the lower limbs is taken as postdictal. Left hand is a mediocre. It can be predictal or postdictal. That's why we prefer right hand and any of the lower limbs. Okay. The saturation should be more than 95 and less than 3% difference. This says the baby, your test is screening is negative. Your baby is less likely to have critical heart disease. Okay? Clear? Can you repeat? Can anyone repeat?
Renuka?
Savita, why can't you repeat?
Right upper limb is representative of preductal.
Very good.
Then lower limb is either of the lower limb is system, sir. And
Okay.
left is neutral, like it can be either preductal or postductal.
Okay.
So we are considering right upper limb and either of the lower limbs, sir.
Okay.
So if it is more than 95% oxygen saturation, it is significant that there is no critical congenital heart disease. And if it's less than 3%.
Very good. Good. That's it. Okay.
So shall I move next to slides?
Yes, yes.
Yes.
Anthropometry, birth weight 1650 gram on femtostat corresponds to 10th centile. Weight of baby on the day of examination 1518 gram. Length 44 centimeter. On femtostat it corresponds to 15th centile. Head circumference 32 centimeter. On femtostat with corresponding gestational age it corresponds to 15th centile. Chest circumference 29 centimeter. Pondering index 1.8 centimeter.
Okay.
Okay.
What less than 10th centile? What does it signify, ma?
It signifies small for gestational age with
good.
corresponding gestational age.
Very good. Good. For ponderal index, why you want to work out this ponderal index?
So this baby is small for gestational age, sir. So I want to know when the insult occurs, whether it is
Okay.
asymmetrical IUG or asymmetrical IUG.
Okay. What do you mean by asymmetrical and symmetrical, ma?
Yes, sir. Asymmetrical IUG means the ponderal index is less than 2, sir. In symmetrical IUGR, it will be more than 2, sir.
Okay. Okay. More than 2.5,
So,
preferably.
Yes,
Yes, sir.
Renuka, so here in this slide, it has been mentioned that the weight of the baby on the day of examination, that is, you have examined on 4th day, isn't it?
Yes, sir.
Okay. The weight of the baby is mentioned as 1518 grams. So against the birth weight of 1650 grams. So this weight loss, is it acceptable? Is it normal? Or is it abnormal?
So it's
acceptable,
acceptable,
sir.
sir.
Acceptable. Okay, that's good. So okay, how much weight loss will you expect?
So in preterm baby, you should 10 to 15%.
Over a period of?
So over a period of 7 to 10 days, 1 week, sir.
1 week, around 1
5
week.
to 7 days.
Okay.
5 to 7 days.
7 days.
Okay.
Okay,
Usually, then what will happen to the birth weight? Then what will happen to
so
the
then
weight?
after surgery, it will try to regain the birth weight, sir, around 10 to 14 days. So.
Okay. Oh.
Roughly,
So
you should remember like this. First 7 days, around 2% per day, around 14% they will lose in a preterm. Okay.
Yes, sir.
Then they regain their birth weight by 14th day. Okay.
14th day.
In a term baby, for first 5 days, around 2% per day, it will lose, and by 5th day, it will lose 10% and regains its weight by 10th day. This is how you are supposed to remember. Okay. Sir.
yeah, yes. The length is around 50th percentile, and already you have answered, but and the head circumference is 50th percentile, but the birth weight is less than 10th percentile. So what does these three values, how will you infer these three values?
So birth weight signifies small for gestational age, sir. Length and head circumference appropriate for gestational age, sir. So there is discrepancy between this. It indicates asymmetrical IUGs.
Okay. In other words, can you put it head circumference alone? What is that? Something will be
So in
spared.
asymmetrical, yes, sir. In asymmetrical IUGR, the length and head circumference difference will be more than 3. So.
Okay.
The something will be spared. Something, there is some sparing effect.
So head
Brain
will be
sparing
spared,
effect.
sir.
Head sparing effect.
Brain
Okay.
sparing effect.
Brain sparing effect.
Brain
Pratima, good,
sparing
ma.
effect.
Good.
Okay. Continue.
Yes, sir.
Very good. Nicely plotted. Good. But you didn't mention whether it's a boy or girl. here in the start it would have been mentioned,
Sir,
no?
yes,
Girls,
sir,
girls,
Oh,
girls.
it's mentioned there. Sorry, ma.
yes.
Sorry, it's my mistake.
Head to toe examination, head normal in size and shape, no overriding of sutures, anterior fontanelle, open, soft on palpation, approximately 2.5 into 2.5 centimeter. Face symmetrical, no dysmorphic faces, eyes equal in size, conjunctiva iris, corneal sclera normal, pupil color normal, reacting to light, red reflex present. Ears normal in size, shape, position and alignment, auricles flexible, no pre-auricular pits, no post-auricular tags, nose midline, symmetrical, no nasal flaring, neck normal, no swelling or other abnormalities, no sinus. Chest normal in shape, movement symmetrical, no chest indrawing, no chest retractions. Breast nodules size 2 mm, nipples normal in position. Umbilical stump, which is dry, shrivel and black in color, still attached, no foul smelling discharge, no erythema around the base. Skull in prone position, normal in straight line, no pits, no tuft of hair, no sacral dimple. Extremities, normal movement of all four limbs, no deformities, superficial palmar crease and plantar creases present, genitalia, clitoris prominent, anal orifice patent. Skin, pink, no birthmarks, no jaundice, no neurocutaneous markers.
Savita, can you go back to the first slide on your head to foot examination? Okay. Regarding the anterior fontanelle, this size is normal?
Yes, sir.
Okay. So any other thing can you add in the description of anterior fontanelle?
Whether it is bulging or depressed, or there is any pulsation present over there.
Okay. So what could be the normal phenomena there?
So
Bulging,
normally
it's not there. Normally it will be?
So slightly depressed as well.
Okay. Okay. So any other fontanelle that could be present?
So in 3% individuals, a posterior fontanelle will be present.
What will be the dimension like?
0.5 centimeter. Posterior fontanelle dimension around 0.5 centimeter.
I don't know. Clinically, how will you tell?
So, it will admit only the tip of little fingers.
Good. Suppose if it is admitting beyond the tip of the little finger.
So it indicates any chromosomal abnormality. Sorry, sir. It indicates any congenital hypothyroidism.
Very good.
Good. Large anterior fontanelle. Any other causes?
Like any metabolic causes like rickets, achondroplasia, or hydrocephalus.
Okay. Good.
Okay. Suppose will you have mentioned no overriding of sutures.
Yes,
Suppose you have examined on the day 4 of life. Okay.
Yes,
so if there were to be any overriding of sutures on the 4th day of your examination, what could have been there?
It indicates any pathological conditions like craniosynostosis.
Craniosynostosis, you will be having the ridges, ridging,
Yes,
ridging.
Molding
initially at the time of birth or within 24 hours. Suppose pathological.
Sir, what sir is asking is any overriding of sutures normally will it occur in a baby or normal weight loss irka baby ka avuma illa andha mari edho kekrar.
Any dehydration.
Very good. Dehydration, when the baby is suffering from dehydration, weight will be
lost. Weight will be
lost,
reduced.
excessively lost. So any baby who is suffering from excessive weight loss at those crucial period may have what? Sutures. Bind in the sutures, the sutures may have, you may have overriding sutures. Okay. Okay.
Any pathological conditions, any insult inside the uterus, any vascular abnormality inside the brain of the baby.
No idea.
Nama?
No idea.
Oh, any vascular insult inside in utero, inside the brain of the baby, that could have caused that maldevelopment of the brain. The brain would not have developed. So there could be overriding of sutures. Microcephaly, small head will be there. Okay. Okay.
When
proceed.
do this anterior fontanelle usually closes by dash months?
1.5 years.
9 to 18 months, 1.5 years.
Good.
Fantastic. Correct answer
9
is
to 18
at
months.
the earliest it can close by 9 months and later it can close by 18 months. So 9 to 18 months is the right answer. Good. Very good. Good. Okay. Next slide. Next slide.
Savita, if the anterior fontanelle is bulging in a preterm baby, what you will suspect?
Any interventricular hemorrhage.
Travel.
Okay.
Okay.
Any other causes apart from
Meningitis.
Very good.
Good.
Good. Very good. Okay.
Okay. Next slide.
Okay. Next slide.
Anything you can expect in conjunctiva that could be a normal variant in a newborn baby.
Subconjunctival hemorrhage.
Very good.
Dr. Sandil, any questions in this slide?
So next slide. We'll move to next slide. Next. Okay. My ears la. This is a preterm baby. Do you want to mention anything special about ears?
So the cartilage is well developed or not?
In this baby, well developed.
Yes, sir.
But usually in preterm, what happens?
So the cartilage, the ear skin is loose and thin. Thin.
Okay, it will be thin, so that if you compress the ears, it will recoil very slowly. Okay, that's what clinically. Okay, fine. Next slide. Sir.
Any questions in?
Sir, breast nodules. Anything significant here?
Yes, sir. So it is less than 5 millimeter, means the breast nodule cannot be palpable. So it indicates preterm.
Okay. This baby, though the ears were well aligned and cartilage are well developed in this baby, breast nodule is small. That's what you would like to mention, right?
Yes, sir.
Okay. So normally the breast nodule size is 3 to 5 millimeter with well-formed nipple and areola complex. And the areola should be darkly pigmented. That should be in the near-term baby. Here it is just 2 millimeter, though the nipples are normal in position. So maybe the baby may also have lesser pigmentation of areola. So this conveys us that this baby is a preterm baby. Am I right?
Yes, sir.
Okay. Okay. Next.
Madam, any questions, madam?
No, sir. No. Let her continue.
Okay.
Continue, Savita.
So extremities, now one previous slide, no? Extremities, what abnormalities will you expect or will you look for?
Sir,
Congenital calippus equinovarus.
Congenital calippus
equinovarus.
Okay. Any other abnormalities you will rule out? Common abnormalities. Any other thing?
Any hip dislocation.
Otherwise called as?
Developmental dysplasia of hip.
Okay. Sandil, any questions?
Yes, yes. Okay. Why are you worried about palmar creases?
There is any chromosomal abnormalities to rule out?
No, in this baby, you are worried about chromosomal abnormalities, or
No,
would like to confirm your point from the beginning? Okay, well, let us say, sorry, this is palmar creases, plantar creases. I would like to ask plantar creases. Does it have any significance here, plantar creases?
Anterior, posterior?
Sir, it signifies, I mean, anterior 2/3 means it indicates preterm, sir.
Okay. Very good. Very good. That's what we expect. Okay. In food, if the plantar creases occupy only anterior 2/3, it means it is more towards preterm. But when it occupies whole of the plantar surface, then it would be more chance for term gestation. That's it. Good. Okay.
Coming to the genitalia, you have mentioned the clitoris is prominent. So does it have any significance?
So it indicates preterms.
Okay. In a term baby, how will it look like?
So the labia majora will cover both labia minora and clitoris.
Very good.
Madam, any questions, madam?
No, sir. Let her continue.
Okay. Dr. Sandip?
Yes, sir. Yes, sir. Let her proceed, sir.
Okay, sir. Proceed.
The skin, pink, no birthmarks, no jaundice, no neurocutaneous markers.
No jaundice. Not even, you couldn't notice a single even yellowish discoloration of eyes even. The baby didn't have any jaundice, or baby had some jaundice.
You couldn't appreciate. Savita, could you appreciate the jaundice, or you couldn't appreciate?
Nothing to get worried, ma. You answer whatever you saw, just mention, ma.
Yes, sir. Yes, sir. No jaundice, no yellowish discoloration.
No yellowish discoloration of skin or eyes. Okay. How will you look for jaundice in a baby, ma? Newborn?
So, under the natural lights.
Very good. And you will
under the
examine
natural
a
light, I
baby
should
under
have to apply. Yes, sir. I apply the pressure over the sternum, forehead, and the bony prominences area. There is no for a while there is no yellowish discolorations after removing the pressure.
Very good. Very good. Okay. That's it. The thing is, when you displace blood by applying pressure over the bones, what happens? Your subcuticular tissue will be visible. Okay. When there is jaundice, the subcuticular tissue will get yellowish tinge. That yellowish tinge you can notice. Why you are more worried about? You are mentioned, sir, one in the sternum, one in the face. Why, ma? Why like that?
Sir, to know the progression of that, sir.
What do you mean by progression? What do you mean by the progression?
So usually the jaundice will progress from cephalocaudal progressions.
Okay.
What is Kramer's rule?
Sir,
you can help.
yes, sir. Yes, sir. Sir, if it is 4 to 6, it's zone 1, sir, and if it's 6 to 8 is zone 2, and if it's 8 to 14, 12 is zone 3, and if it's 12 to 14 is zone 4, and if it's more than 15, it's zone 5, sir.
What are all the landmarks for all these zones?
So zone 1 is like head and neck, sir, and zone 2 is like thorax and abdomen. Zone 3 is genitalia and thigh. Zone 4 is upper limb except hands and leg. Zone 5 is extremities, palms and soles, sir.
Okay, good. Almost okay. Good. Yes, okay, why this is happening, ma? Why it is having this cephalocaudal progression, jaundice? Do you have any idea?
No
idea, sir.
Your heart is pumping blood, ma. Okay.
Yes.
Okay. Your heart is pumping blood. The vascularity will be maximum in the face or in the fingertips?
Face.
Yes, that's what. Very simple answer is vascularity. Very simple answer is, though there are multiple other reasons. As an undergraduate, this is fine. Vascularity is the reason for cephalocaudal progression. That's what Kramer's, who has labeled out. He divided into zones and made it clear. It progresses in such a way, and he has correlated with serum bilirubin. Okay, normally, okay, does jaundice occur in all term babies and preterm babies?
Physiological jaundice, it occurs.
Okay.
Like
okay, ma. Normally, how does physiological jaundice, when will it appear and when will it disappear?
Sir, after 24 hours, sir. It will be then it peaks by 3 days, sir.
Very
and
good.
It vanishes within a week, sir.
Almost. Very good. In preterm?
Preterm, it's prolonged, I think so, sir.
Yeah, that's okay. This is enough for you. Okay, it usually appears after 24 hours of life. Here, third and by it peaks later on, right? By third and fourth and fifth day, it plateaus and it comes down. And in preterm babies, this peak can last for few days, depending upon the feed intake and severity of the illness. And usually, physiological jaundice should disappear within 2 weeks. Any jaundice beyond 2 weeks, usually it disappears by 7 to 10 days, but any jaundice beyond 2 weeks of life is abnormal. Any jaundice within 24 hours of life is abnormal. Okay?
Yes, sir.
Okay. Do we have any serum bilirubin cutoff to say whether it is physiological or pathological jaundice?
Yes, sir.
What is the serum bilirubin?
If the serum bilirubin is more than 15 milligram per deciliter, it's pathological, sir. And if direct bilirubin is more than 2 milligram per deciliter at any time, is pathological.
Very good, ma'am. Okay.
And
go ahead.
Why babies are more prone for jaundice?
Because immature liver, ma'am. So UDP glucuronide transferase is insufficient to conjugate bilirubin.
Yes. In term babies also physiological jaundice is
and the regulation.
Anything
other
else?
causes of
Polycythemia, so increased red cell mass. And
it is not polycythemia increased. Yes, increased. Yes. Actually, this. You go ahead, ma. You tell. Yeah.
Then like a half-life of RBCs is reduced. It's around 90 days when compared to adult RBCs. So increased destruction will lead to increased.
Okay. You just don't use the term destruction and all. Then it belongs to pathological jaundice. You tell increased RBC turnover rate. Increased RBC turnover rate. Okay. Increased RBC turnover rate and your liver immaturity is the major cause. Along with that, enterohepatic circulation if the feeding is delayed or anything else. Okay. Good, ma. Now, I would, Renuka, you yourself answered this question. Tell me 4 differences between physiological and pathological jaundice.
Sir, physiological jaundice, like it occurs after 24 hours. Pathological jaundice, it is like it occurs within 24 hours. If it occurs between 24 hours, it's pathological jaundice. And physiological jaundice is usually it disappears by 2 weeks, whereas pathological jaundice, it's prolonged after 14 days, 2 weeks. So then physiological
serum levels you told.
Yes, sir.
Yes. You that is also a difference, no? You mentioned it. Just you can mention it.
If the serum direct bilirubin is more than 2 mg per deciliter at any time, it's pathological jaundice. And if the serum bilirubin increases by more than 5 milligram per deciliter per day, it's pathological, sir.
Okay. Or serum bilirubin more than 15 milligrams percentage. And when the severity of the jaundice, when it involves palms and soles, that too, it is pathological jaundice. Finally, any jaundice requiring treatment in the form of phototherapy or exchange transfusion is pathological jaundice. Okay?
Yes, sir.
Good. Very good, Pratibha. Very good. Fantastic. Obstructive jaundice, you have told no.
Yes. Pratibha, can you tell what is breastfeeding jaundice?
This jaundice occurs due to inadequate breastfeeding.
How will you manage?
Frequent breastfeeding should be given within 2-3 hours. Frequent breastfeeding should be given to the baby, and
yes. Mother has to be supported, and we should ensure the baby is receiving adequate feeds. That you want to mention, right?
Yes, sir.
Okay.
Renuka, what is breast milk jaundice?
Breast milk jaundice is because of the constituents present in the milk. It leads to decreased conjugation of bilirubin, like pregnandiol and lipase, which decreases the conjugation of bilirubin. So.
Okay. Good. Very good. Very good.
Yes.
does it harm the baby, ma? Breast milk jaundice?
No,
Will
sir.
it harm?
No, sir.
Yeah.
Breastfeeding can be continued.
Though the value of bilirubin may be high in breast milk jaundice, it won't cause major harm in a neonate. That's why, though in a very good feeding baby, though they have this high level of bilirubin, we are not that much bothered as other pathological jaundice. Okay, very good, fantastic, ma. Now jaundice, you are clear. What is the treatment we give for jaundice, ma?
The phototherapy is the treatment.
Okay, phototherapy. Have you seen any baby
We are
under
giving
phototherapy, ma?
phototherapy of 460 to 490 phototherapy, and if it is very severe, we are giving a double exchange blood transfusion.
Double exchange or double? Missed one word. Double volume.
Blood trans.
Double
Exchange
volume
transfusion.
exchange transfusion. Okay.
Transfusion.
Double volume exchange transfusion. Okay. So
Okay,
Sir is asking something.
yeah, ma. When the baby is kept under phototherapy, have you seen anything covered, or what are the precautions you will take, ma?
So usually the baby's eyes are covered to protect from the UV rays, and so the baby is not having any cloth.
Very good.
In any other part to be covered?
So genitals and the eyes are covered.
Very good, very good, ma. So except for genitals and eyes, the baby should be uncovered. Okay, right. Fantastic, ma. Then you will ensure what? When the baby is in phototherapy, you will ensure what?
So
Yeah. What will happen to the baby when you are giving excessive light? Because that also involves some amount of heat energy there. So what will happen to the baby?
So hypothermia can be
Okay,
can be
accepted.
prevented.
Okay. Okay, then any other thing? What happens to the body fluid composition? Savita?
The bilirubin used to get excreted in urine only, ma. You should ensure adequate urination. How will you ensure adequate urination?
So 1 to 3 ml per kilogram.
So IV fluids are given.
No,
IV
no. Not all the babies. You need not give IV fluid.
At least past 6 to 8. At least past 6 to 8 times per day, sir.
No, not for urine output. Sir is asking not about the urine output. The baby gets rid of the jaundice by excreting the bilirubin in the urine. So what should be given?
Every 2 hours, what should be given, ma?
Express breast milk should be given.
Not be expressed. Adequate feeding should be ensured.
Feeding should be given. Okay. So how many percentage of excess of intake of feeds or fluids should be given? Excess. Any baby under radiant warmer or phototherapy?
10 to 20 ml per kilogram per day.
10 to 20%. Okay. Dr. Sendil, any questions?
Yes, sir. Yes, sir. Jaundice, I wanted to discuss, sir. That's why we are discussing.
Okay,
I think
no problem. Any other points? Any other points?
Yeah.
Any questions, sir?
Okay, ma. In what all the changes? Let us take. One mother is complaining. The baby says develop some rashes after keeping in phototherapy. You are there. What will you advise to the mother, ma? Is it harmful?
So it may be normal erythema toxicum appearing on the baby.
This is normal. Phototherapy rashes can happen when you place a baby under phototherapy. Okay. The phototherapy, what sort of phototherapy we use, ma? Only on the upper side or in the lower side?
So upper side only.
Only upper side.
Only upper side.
That is single surface phototherapy. Double surface phototherapy means you can give from both the sides, from upper and also from the lower. You would have seen it in the babies being placed over a transparent acrylic sheet in the warmer, under the warmer, and the phototherapy will be there, one over the baby, and the other source of light will be coming from the
Below.
from the below. Okay.
Yes.
So that is double surface phototherapy. Suppose if the jaundice is more, then the most of the skin should be exposed to phototherapy. So we need double surface phototherapy. Okay.
What is the color of the light, ma, which we commonly use during phototherapy? Have you seen it?
Blue
Have you
color.
seen it, ma?
Blue color. Sir.
Blue color, fantastic, ma. This is preferably we use blue color. Actually, it correlates to 450 nanometer. That's why we use blue color, which is very useful to convert our unconjugated bilirubin to water-soluble bilirubin, which gets excreted in babies' urine and stools, and thereby getting rid of pathological jaundice. Good, very good, fantastic, ma. Can you name few causes for pathological jaundice, ma? One or two.
Cholestasis, sir.
Very good.
Commonly, cholestasis, except any other thing.
Then
Day one
is hemoglobinopathy, sir.
Commonly.
Hereditary spherocytosis. Sir.
This is also very rare, my.
ISO immunizations.
Very good, Savita. Very good.
RH incompatibility.
Any other incompatibility?
ABO incompatibility.
Very good. This is what we expected from you people. Okay. And
Common
then
things
anything
are
else?
always common. Common things are always common. Okay.
RH, ABO, and anything else, ma? Intrauterine, you are telling about some torch and all can cause jaundice?
Toxoplasmosis.
Yes, intrauterine infections. Need not mention about the names. Intrauterine infection. Any intrauterine infection can cause jaundice from day one. Okay, that's it. That's it. Okay, sir. Shall we move, sir? Shall we move to the
Yes.
next slide?
Yeah. One more question here.
Yes, sir.
You have mentioned no birthmarks. What do you mean by that?
Birthmarks.
Mongolian spots.
So it was not there.
Yes, sir.
So you expect that, or?
So usually it will be present in the babies, sir, around, it will disappear around 1.5 years. Sir.
Okay. So what are the normal variants that is present in a newborn that might be alarming to the parents, but you can reassure?
Mongolian spots.
Okay. Any other thing?
Erythema toxicum.
Erythema toxicum.
Very good. Very good.
Mastitis neonatal.
Okay.
Milia.
Okay.
Any vaginal discharge and
Very good. Vaginal discharge alone or something else?
vaginal
Mastitis
bleeding.
neonatorum.
Vaginal bleeding, mastitis neonatorum. Okay.
Suppose in a vaginal bleeding, around which day is normal? Due to what?
Due to withdrawal of maternal estrogen hormones.
Very good. Very good. Fantastic.
Good. Okay.
Very
Okay.
good. Okay.
Then any other thing? Suppose if it were to be a male child, any whitish thing?
That you can notice in the palate also.
Palate
Same
also,
thing.
same thing.
Epstein pulse.
Epstein pulse, very good.
Epstein pulse, very good. Yes, sir, they are very good in finding out normal variants. Good.
Madam, any questions, madam?
Nothing, sir. Let them continue.
Okay. Proceed.
Savita, presentation.
Systemic examination. CDS. Apical impulse felt at left to fourth intercostal space, lateral to midclavicular line. First and second hearts are here. No murmur. RS. Bilateral air entry present. No added sounds. No signs of respiratory distress. Abdomen soft and protruding.
Apical impulse is in the right side. What you call?
Dextrocardia.
Okay.
Suppose some pathological conditions that could have caused the shift of the apical impulse somewhat medially than what you have mentioned. Any other conditions? The child will be presenting with some respiratory distress. Scaphoid abdomen and
Congenital diaphragmatic hernia.
Very good. Excellent.
very good, very good.
Excellent.
Very good. Very good.
Madam, any questions, madam? Any other questions?
Then what will happen to the breath sounds in congenital diaphragmatic hernia?
Will be reduced from a congenital diaphragmatic hernia. It will pushes the lung, ultimately leads to pulmonary hypoplasia.
Yes.
So
yes. So you will not be able to hear breath sounds in the left side.
Yes, ma'am.
Instead of breath sounds, there may be sometimes it may be
Yes,
there may
sir.
be some noises heard. What could
Yes,
be
sir,
the
due to intestine, the stomach, gastrointestinal contents will be
Gurgling sounds. The gurgling intestinal sounds in the ear in the left hemithorax. Okay. Normally, this diaphragmatic hernia, it occurs in the left side, which we call it as Bogdalak hernia. Usually, it occurs in the left side. So it pushes the heart to the right, and almost you won't hear any breath sounds in the in the left side, and maybe you may be hearing gurgling sound. Good, very good, ma.
Okay, any other thing
continue.
in the abdomen that could be there in the examination to point out that there could be some intrauterine pathology?
duodenal atresia.
Okay, duodenal atresia. Okay, duodenal atresia in case of what?
Down syndrome.
Down syndrome. Okay. Okay. Any other clinical examination? Duodenal atresia, you won't be having any clinical finding. I am asking you. You mentioned soft protruding abdomen. Let me say that the child have hepatosplenomegaly. So it's a LBW baby. So it's a partial IUGR also. So what could be the etiology when you have hepatosplenomegaly?
They are not able to understand completely.
Hepatosplenomegaly, ma.
Give another clue. Some other clue you give.
Cytomegalovirus infection.
Very good, very good.
Okay, torch, one of the torch components. So intrauterine infections. Okay.
Savita, I am hearing a murmur in the fourth intergal. Let us say all over the left hemithorax, I am hearing a murmur, which is almost happening in both systole and diastole. So this is a preterm baby. What should I get worried now, ma? What would be the reason for that murmur?
Patent ductus arteriosus.
Very good. What is that murmur?
Holocystolic.
Patent ductus arteriosus?
Classical murmur description.
Classical.
Sarah has told both phases.
Systolic and diastolic.
Continuous
Murmurs. Continuous murmurs.
Continuous machinery murmur. Very good.
Yes,
Fantastic. Good. Okay. In RS, respiratory system, what complications you will expect in a preterm?
Respiratory distress syndromes.
Okay. What do you mean by respiratory distress syndrome?
In preterm babies, sir, before less than 34 weeks or something, there will be surfactant production will be low, sir. So the LS ratio, lecithin sphingomyelin ratio will be low, sir. So the alveolar tension will be reduced. During expiration, the lung will collapse, sir, and it will further leads to hypoxemia. It will further result in pulmonary constriction, sir. After it will result in there will be exudate necrosis and exudate formations will happen in the alveoli. It will result in hyaline membrane disease. Histologically, we call it as a hyaline membrane disease.
Membrane disease. Okay, very good. Excellent. This is a disease of surfactant deficiency, respiratory distress. Then what would be the treatment for these diseases?
If there is mild, based on the scoring system, sir, in preterm we will use
let us take this is hyaline membrane disease. This is severe hyaline membrane disease.
Surfactant therapy.
How to give surfactant?
Intratracheal.
Laryngeal.
Intratracheal.
Tracheal.
Good. Okay. Understand? So
So
we call
any
it
other?
as, yes, sir, yes, sir.
Continue.
Yes, we call it as surfactant replacement therapy. Depending upon the severity of illness, you may need to repeat the dose. We give surfactant nowadays. Whatever the surfactant we give us through intratracheal. Okay. Though there are a lot of techniques by which we give, which you people need not be aware of, but surfactant has to be given intratracheally. Okay. What is TTN, transient tachypnea of newborn? Will it occur in preterm?
Sir,
No, sir.
no, sir.
No, it can happen in preterm also. Okay, that's what you told. No, depending upon the severity, I will manage even transient
Yes, sir.
tachypnea may happen along with respiratory distress syndrome. These two respiratory problems can occur in a preterm: RDS and respiratory distress syndrome or hyaline membrane disease, and transient tachypnea of newborn. Good. So in cardiovascular system, we are worried about one is patent ductus arteriosus, second is shock. These preterm babies will go for shock abruptly than in a mature term baby. These are the two complications in cardiovascular system in any preterm baby. Okay. In respiratory system, you should be worried about hyaline membrane disease and uh, transient tachypnea of newborn. Okay. Good.
Renuka, suppose if this baby is less than 32 weeker,
Yes, sir.
let us say that this baby is less than 32 weeker, and
Yes, sir.
what other complication you can expect in the respiratory system?
Sir, any apnea of prematurity, sir.
Very good.
Yes.
Okay. So at what age will you expect apnea of prematurity to occur in a preterm baby? At what day of life? Around what day?
Sir, no, like around, no ideas.
Okay, no problem. Around after 2 days of age. Okay.
Yes, sir.
So how will you manage apnea of prematurity?
Sir, caffeine can be provided to the newborns.
Okay.
Caffeine.
Before that,
Tactile stimulation.
tactile
Tactile
stimulation. Very good.
stimulation.
Okay. So how will you define apnea?
Sir, if the cessation of respiration is more than 20 seconds without any grunting or retraction, chest retraction, sir.
So okay, with or without?
Cardia cyanosis. Bradycardia cyanosis.
Okay. Good. Okay. So I think that after this slide, have you mentioned anywhere about cardiovascular system, Savita?
Sir.
No. Okay. So I think that you can add one more thing in the examination of cardiovascular system in a newborn baby. You can mention one pulse.
Femoral pulse.
What is its significance?
To locate the coarctation of it, whether it is pre-ductal or post-ductal.
The femoral, we are mentioning about the femoral pulsations. So either it is present or not.
Yes, sir.
Okay. So it should be mentioned, all newborn babies after 24 hours of life, you have to mention the femoral pulses. At least once before discharge, it should be documented. Whether the femoral pulses are well felt or not, it should be documented. Okay. Dr. Sendil? Madam, any questions, madam?
Yes, no, sir. Let them continue.
Okay. So any other finding in the abdomen on examination, on general examination, head to foot examination in the abdomen?
Any redness over the umbilical stump?
Okay.
Or any scar.
Okay, scar.
Newborn scar.
Discharge in the stump, sir.
Okay, that you have mentioned. You have mentioned all those things. Anything protruding, protuberant abdomen is normal in a newborn. That's acceptable. Okay. Any other thing?
Very good. Abnormalus, omphalocele.
So what is its significance?
Any neonatal sepsis, sir.
Sepsis. Omphalocele, umbilical hernia.
Sir,
Umbilical hernia ன்னு சொன்னீங்கன்னா any
herniation.
Huh? Umbilical hernia, any significance?
Vitelo-intestinal.
Umbilical hernia. This is not discharge. Sir is not
Okay,
asking for
sir.
umbilical discharge.
So delayed closure of abdominal wall.
Okay. அது
Okay.
வந்து
Any abdominal wall
Okay.
Effects.
disorders, prone belly syndrome.
prone belly syndrome. Okay. Okay. So simple. You have mentioned something about that previously. Posterior fontanelle லாம் சொன்னீங்கல்ல.
Wide open posterior fontanelle.
The
Congenital hypothyroidism.
Umbilical hernia. Now, you Pratibha, you have given the answer for normally happening umbilical hernia in a growing preterm, which can happen, and it may take 6 months to 1 year to get completely resolved, which says that there is a weakness around the umbilical region. That's it. But any baby with umbilical hernia, certainly we should rule out hypothyroidism. We should check. Otherwise, because congenital hypothyroidism is a treatable cause of dash.
Mental retardations.
Very good. Excellent. That's what.
Mental
Okay.
retardation.
Madam, any questions, madam?
No, sir. Let them continue.
Okay. Proceed, ma'am.
CNS examination, higher functions, state-to-state variability is normal. Motor system examination, pull to sit, complete head lag present, ventral suspension, complete lack of head control, supine cushion, head turned to one side, and prone position, head turned to one side, pelvis high, range of movements normal in all four limbs. Cranial nerve examination, olfactory, baby turning the head to breast milk smell, optic nerve, blinking of eye to bright light, oculomotor, trochlear and abductor nerve, doll's eye reflex, trigeminal nerve, rooting reflex present, facial nerve, no gross facial asymmetry or no deviation of nose during flight, vestibulocochlear nerve, startle response present, glossopharyngeal and vagus nerve, no nasal regurgitation of fits, no drooling of saliva, spinal accessory nerve, normal neck movements. New modified Ballard score, physical maturity signs include six components: skin, smooth, pink and visible veins, the score is 1. Lanugo hair, thinning, the score is 2. Plantar, pieces on anterior tooth, the score is 3. Breast, stipple areola and 2 mm bud, the score is 2. Ear, well curved pinna, soft but readily recoil, score is 2. Genitalia, clitoris prominent and enlarging minora, score is 1. Total score of physical maturity sign is 11. Neuromuscular maturity sign, posture, the score is 3. Square window, the score is 2. Arm recoil, the score is 4. For popliteal angle, the score is 3. Scarf sign, score is 2. Heel to ear, score is 1. Neuromuscular maturity sign score is 50. Total Ballard scoring 26. Reflexes, rooting reflex present, sucking reflex present, palmar grasp present, plantar grasp present, asymmetrical tonic neck reflex present, moro reflex present.
Previous slide, no? Previous slide. One more previous slide. Okay. So total Ballard score is 26. What is the minimum score and what is the maximum score? And between what gestation ages we can use this Ballard score, new Ballard score?
From 20 weeks.
Minimum score minus 10, sir, and maximum score is 50, sir.
Very good.
Okay.
Excellent.
Okay. Between what gestation ages this Ballard score is applicable?
From 22 weeks to 44 weeks of gestation.
That's Sendil. Any questions in this neuromuscular maturity? Ballard score? Dr. Sendil? Madam?
No, sir. Let them continue.
Okay. Suppose at what gestation age you have the scoring, the total Ballard score and the gestation age are the same?
40 weeks.
Around 40 weeks of gestation.
Very good. Very good. Very thorough about new Ballard score, sir.
Okay.
Very good. Sir, can I ask?
Yeah,
You
continue.
mentioned
Yes, sir.
state-to-state variation. What do you mean by state-to-state variability, Pa? In higher functions, you have mentioned state-to-state variation, right? Variability. What do you mean by that?
Variability. So there are 5 states, sir.
Hmm.
Sir, first state, the baby will sleep well, sir, in first state.
Okay.
In
See,
second state,
for
the
an undergraduate level, you need not know all the states. That doesn't need. Okay. As
Okay,
an
sir.
undergraduate, you should know. See, the baby will have hunger cry. It
Okay,
will
sir.
feed. It will take breastfeed. Then it will be playful for a while. Then it will go for sleep. This cycle is called this variation. No, this is
Yes, sir.
state-to-state variability. Even when you mention in general examination, try to include like this. Okay,
Okay, sir.
you can present like this. During the course of examination, baby was alert, active. Okay, moving,
Yes, sir.
having symmetrical limb movements, and you can also you can use this terminology during this. Now you can present like this: baby is sleeping in the mother's lap, but during the course of my examination, baby was awake, alert, active, with symmetrical limb movements. Like that, if you say, even in general examination, you have made it clear to the examiner that the baby's higher functions are fine. Okay, try to
Okay,
use
sir.
this terminology. Okay,
Okay, sir.
alone simply by saying state-to-state variability, it looks very blank. Try to include this. Okay, fine.
Okay, sir.
Fine. Then followed by higher functions, always you should continue with cranial nerves, and then you can go for motor system.
Motor system.
Okay,
Okay,
higher
sir.
functions, cranial nerves, and then go for motor system. Okay, motor
Okay, sir.
system, instead of you can use these pull to sit, all those. Try to say, sir, I would like to do both assess both active and passive tone. Active tone is posture, you can mention. Passive tone, you have assessed, no, by pull to sit, all those stuffs that you
Yes,
can
sir.
mention. Okay, even
Okay,
in
sir.
active tone can be assessed by handling, by pull to sit, every whenever you can assess active tone. And passive tone, how did you assess in all the joints? You can mention. Just you can mention. I have assessed tone passively in all the joints, and the tone is normal. It's not flabby, or it's not flaccid, or the tone is not hypertonic. You can mention like this. Okay. In motor system, try to mention active and passive tone. That would be very easy for you people to remember. Okay.
Okay, sir.
If you hold the baby in an erect manner, you can assess both the lower limb tone. If you make the baby lie on your palm in a prone state, you can assess both upper and lower limb tone and your vertebral column. Almost your spine tone will be assessed. Okay. If you
Yes.
put the baby in your palm or the back, you can assess back muscles and neck muscle. You can assess. Okay. Like that. This is what you have mentioned. When you keep like this, you are assessing active tone. When you are making passive movements around a joint, that is passive tone. Okay. Higher functions, cranial nerves, almost every cranial nerve can be examined, as you rightly mentioned. Very good. Fantastic. Good. Then motor system you have covered. This is more than enough. Next slide. Yes. Maturity scoring. If you remember, at least you should remember 4 or 5 physical. You will be given the scoring system, but you should remember at least 3 or 4 physical and 3 or 4 neuromuscular grading system. Okay. Which says the difference between preterm and term baby. Okay.
Yes, sir.
Madam.
Let them continue, sir.
Okay, madam.
During the examinations, you will be allowed to take these charts. Okay, so
Okay, sir.
as sir told, you can remember a few, and during examination, you can see the charts and assess. Okay.
Okay, sir.
Continue.
Continue.
So previous slide. So These reflexes. Okay. How will you look for Moro's reflex?
We have to hold the baby in our hands in prone position, I mean in supine position. Suddenly we extend the head means there will be a opening of hands, extension and abduction followed by flexion and adductions.
Last component.
Prona.
Cries.
And cries, the baby will cry.
She has corrected. She has corrected.
Okay.
Where you will get asymmetrical Moro?
In case of clavicle injury or
Brachial
brachial
plexus.
plexus injury or humerus bone injury.
Very good. Fast. Very
What is ATNR?
Whether the Moro will be complete or incomplete.
After 37 weeks, there will be mature. When Moro reflex will mature.
Okay. So the last component of Moro's reflex is?
Flexion and adductions.
Followed by a
Cries.
Cries,
yeah,
followed by
good,
cry,
good.
yes.
Yeah, okay. Okay. What is ATNR?
Asymmetrical tonic neck reflex.
What is the posture called in ATNR? It goes by a name.
Tensing postures.
Tensing posture. Good. Dr. Sendil, any questions?
Yes, sir. When will these reflexes will disappear, ma? Normally.
Around 4 to 6 months.
Okay. If this reflex occurs in a baby of age 1 year, what will be your inference? Almost all these reflexes are present. What will be your inference?
Any neuro regressions?
Very good. Any neurodevelopmental disorder, maybe neuroregressive disorder, whatever it may be. Okay. So this we used to call it as primitive reflexes. Okay. These primitive reflexes has to disappear, except one primitive reflex which lasts for lifelong. That is parachute reflex. Okay. Fine. This root suck and swallow reflex gets coordinated at what weeks of gestation?
At 37 weeks of gestation.
Sir has told you.
So 34 to 36 weeks.
Why you want to know that, ma? Why you want to know that? By knowing that root suck swallow gets coordinated by 34 weeks, what can I do to the baby? What can I allow for the baby?
Oral feeding.
Very good. Not oral feeding, even
breastfeeding.
Direct breastfeeding.
Direct breastfeeding.
Okay. Good. Most well
Suppose
done.
if, let us say that if a baby being born below 28 weeks, so what will be your nutritional support for that baby?
Intravenous
IV
intravenous
IV
nutrition.
Fluids. Okay. So any baby born between 28 and 32?
Nasogastral tubes.
Okay. Nasogastric or orogastric? Which one is preferred? Orogastric. Okay. So any baby born between 32 and 34?
Aladi feeds.
Okay. So by instituting this one, so will you continue to give the same type of feeds, or will you improve or increase the feeding pattern?
The feeding pattern will be introduced. So, like if the baby is on NG tube, he will be allowed to have 2 ml of or 5 ml of express breast milk, sir, and see if he or she can progress from that.
So let me take these questions in the other way. So what do you mean by trophic feeding?
Maturation of the gut, sir. It's given.
It is given for only for not for calorie requirements, for gut maturity.
Priming of the guts.
Okay, priming of the gut. Good. So in VLBWs, so we give small amount of feeds to prime the gut. Okay. Okay. Yes. What do you mean by non-nutritive sucking?
So
non-nutritive sucking.
Sir, in a preterm, baby, they to develop the sucking reflex, they are given so plastic. They are to develop the sucking reflex. It is done to the preterm babies.
Okay. So what other advantage for the mother? What is the advantage for the mother when you allow the baby to suck at the breast? Renuka?
Sir, sir, as the earlier the baby is put onto the breast, the breast ejection will be more, sir. Like more breast milk will be secreted.
Okay.
Very
Okay.
Then skin to skin contact
Okay.
What is
will
it?
cause bonding
What is
between the
called
mother
as
and baby.
that skin to skin? No, skin to skin contact. No. What do you call that
Yes.
method as?
Kangaroo mother care, sir.
Very
Kangaroo.
good. Very good. What are the benefits of kangaroo mother care?
Sir, benefits of kangaroo mother care is skin to skin contact will provide bond it provide warmth to the baby, sir. Then exclusive breastfeeding will be initiated. Then
Decreased risk of infections.
Very
decrease.
good. Very good.
Then
Decreased risk of respiratory distress or
Distress.
apnea.
Apnea. Okay.
apnea accepted.
Apnea. Okay.
Apnea.
Something with temperature, ma?
Thermal synchronization will occur.
Reduced risk of hypothermia. Very good. Then more dash gain. What will be
Weight gain, sir. Weight gain will be more.
It promotes less infection, more weight gain. These are the uses. Let us take, you have told that between 32 to 34 weeks, we express the milk and we used to give to the baby by oral paladai, right? Now we have expressed milk from the mother. How long we can keep that breast milk in room temperature, ma?
6 hours, sir.
It's 8 hours. Okay,
Yes.
6 to 8 hours. 8 hours. Good.
Refrigeration?
24 hours, sir.
Okay. Suppose in a breast milk bank, we have seen breast milk bank being functional in our hospital. No?
Yes, sir.
So in deep freezer, up to what period we can store the breast milk?
3 months.
Okay. At
Okay.
minus 20 degrees centigrade. Okay. Okay.
So let her finish the diagnosis, sir. Then we'll go.
Okay.
Hello, panelists. Just a gentle reminder, we have 25 minutes here.
Avita, next slide.
Sir?
Next
Yes,
slide.
sir.
Yeah.
Diagnosis: a late preterm female child, 35 weeks and 4 days of small for gestational age, low birth weight of 1650 gram, with asymmetrical intrauterine growth restriction, with no preterm complication, without any obvious congenital anomalies.
Okay, now how old is the baby now, ma?
Sir, 4 days.
4 days old. Okay. You will give breast milk alone, or you want to supplement something else?
Sir, breast milk along with multivitamins, iron and calcium, sir.
Iron, will you start now?
So no, sir. At 2 weeks of postnatal need.
Okay. You will start after 2 weeks. What calcium alone will you start, or along with
Along with
calcium
vitamin
something
D,
else?
sir. Along with vitamin D. Sir.
Vitamin D. Who is the friend of calcium, ma? One
Vitamin
more friend
K,
is there.
sir.
Mm-hmm.
Vitamin K.
Vitamin K. When it has to be given, ma? Vitamin K.
At the time of birth.
Same.
Okay.
At the
At
time,
the time of?
At the time of birth, sir.
Okay. How much? How to give that vitamin K?
intramuscularly, sir.
Very good. How much?
Sir, less than
1
1000
kg.
kilograms, 0.5 milliliter.
Very good. More than 1000?
Sir,
1
1
1
milligram.
milligram.
1 milligram of vitamin K.
K,
1,
sir.
2, 3, 4.
K1.
One.
Yes, sir. K1, sir. K1.
Very good. Very good. Fantastic. Okay. What supplements will you give for this preterm baby?
Sir, calcium,
Proteins.
vitamin D, phosphorus.
Very good. 2:1 ratio of calcium and phosphorus. Okay. You should know the dosage also, ma. Better. You should know the dosage. Okay. Fine. That is 140 to 160 milligram per kg. If you know for calcium, that is enough, no? 2:1 ratio. Phosphorus will be half of it. Right? Okay. Vitamin D, how much vitamin D will you give?
400 international unit.
Very good. How long will you give?
Sir, for up to 2 years.
1 year. 1 year of age. Okay. For term baby or preterm baby, up to 1 year of age. Very good. Okay. When will you start iron? You have given the answer already. When will you start iron, ma?
Sir, 2 weeks, sir. 2 weeks.
Beyond around as early as 2 weeks, but 2 weeks if the baby is otherwise devoid of any infection or active distress or active disease, we won't start. If the baby is devoid of it, we can start as early as 2 weeks of life. Okay. Iron we used to start with prophylactic dose 2 to 3 milligram per kg per day. Okay, what is the therapeutic dose of iron, ma? The baby is having anemia, let us say.
Yes, sir.
How much iron will you give?
5 milligram.
Okay.
6 to
4 to 6. 4
to 6
milligram.
Very good.
Any other vitamin? Any other vitamin in a very preterm baby?
Vitamin B12.
Think.
Vitamin K and vitamin D. Vitamin E.
Okay. That we used to supplement as multivitamin. Okay. In the multivitamin, almost all these vitamins are available.
How long will you give these multivitamin supplementations in a preterm baby?
Around 6 months.
Till they achieve the 40th week of gestation. Okay. So up to that, it's mandatory to give these multivitamin supplementations, because during the third trimester only, lot of minerals will be accretion. Mineral accretion will be happening inside the uterus for the fetus. So that is compromised when the baby is being born preterm. Okay, you need to supplement vitamins and minerals up to the age of 40 weeks. Okay. So what will happen if these calcium and phosphorus are deficient? What do you call that condition?
It leads to osteopenia of prematurity.
Very good. Osteopenia of prematurity. What will be the clinical feature, ma, in osteopenia of prematurity?
So there will be bowing of leg. Clinical features.
Craniotypes, bowing of legs. Then,
pectus excavatum.
very good.
Harrison sulcus.
Yes.
Rachitic rosary.
Very good. How will be the sensorium of the baby? Very joyful, very irritable, or apathetic. How would the baby will be?
Irritable, sir.
Very good. The main clinching point in the diagnosis is if the preterm baby, otherwise with poor weight gain, comes to you with irritability and any of these features, craniotypes or bowing legs or rachitic rosary or your Harrison sulcus, then you can come to a conclusion that the baby is suffering from osteopenia of prematurity. Good. The calcium and phosphorus, both along with vitamin D, may be low. So we need to treat for it. So we are giving this calcium and phosphorus supplementation to prevent this osteopenia of prematurity. Okay, very good.
So what other complications can you expect in a preterm baby, generally?
Metabolic causes like hypoglycemia, hypocalcemia.
Okay.
Hypothermia.
Basically hypothermia. Okay.
So then system-wise from CNS, interventricular hemorrhage, periventricular leukomolysis.
Okay.
So in respiratory distress, respiratory system, respiratory distress syndrome. So in chronic cases, bronchopulmonary dysplasia.
Okay.
In GIT, there will be a recrudescing enterocolitis.
Okay.
Hertzsprung disease. Hertzsprung disease.
Preterm,
specific to preterm. So any other thing you have to screen for?
Retinopathy of prematurity in eye.
Very good.
So what type of preterm babies what is the indication of retinopathy of prematurity?
Less than 32 weeks of gestational age, or the birth weight is less than 1.5 grams, 1.5 kilogram.
Okay, 34 weeks. Dr. Sindhu?
Among sir. Now, as per Indian guidelines, actually abroad the AAP says less than 32 weeks, but as per Indian guidelines, it is 34, sir. Less than 35, that is 34 and below has to be screened. All those babies, and in our Indian criteria, it goes up to 2 kg, sir. It's not 1.8.
Okay,
It's 2 kg. Yeah.
Less than 2 kg. Okay. So any other what other complications that can be associated with preterm? Any other thing? We have discussed already. When you are telling about these complications, when you're asked, in theory also you may be asked an essay. So you have to write about all these things. Then one more thing, previous you have discussed. Pratibha?
Pattern ductus
Yeah, okay.
Good. But all the babies having pattern ductus arteriosus, babies having active disease, babies going for failure. What should I do, ma? Do we have any treatment for it? Medical management for pattern ductus arteriosus, I am asking you.
Indomethacin.
Very good. IV indomethacin. Now almost we replace IV indomethacin is replaced by some other drug.
Common drug. Fever drug. Common fever drug.
Paracetamol.
Okay. Almost it is equivalent. Paracetamol. Very good. Fantastic. Good.
One more thing we need to screen in these preterm babies.
Hearing.
Okay, good.
Very good. The follow-up, you are supposed to look for hypothyroidism. IVH, you need to rule out. You are supposed to look for USG cranium, and you should rule out any retinopathy of prematurity. Definitely, you should have screened all these steps before 40th week of gestation. At least once you should have screened for it. Okay. And then what growth charts you use, ma, in these babies?
Penton growth charts, sir.
Okay. When these babies gestation goes beyond 40 weeks, what else chart you use?
World Health
In pediatrics, what's your growth?
WHO growth
WHO.
chart.
Very good. Excellent. WHO growth charts. After 40 weeks, up to 40 weeks, you can try Fenton's chart. Only disadvantage in Fenton's chart is we have discussed for first 5 days or in preterms for first up to 7 days, there will be weight loss and it may take 1 more week to gain its original weight. That is day 14 in preterms, no. But this won't be there in your Fenton's chart. That is the problem. But otherwise, the gold standard is intrauterine growth charts, which we use, Fenton's chart. After 40 weeks, our routine WHO growth charts serves our purpose. Good.
Suppose during the follow-up, when the mother comes and complains of that my baby is not gaining adequate weight, what are the things you will look for? Renuka?
Sir, once more, sir.
Suppose during follow-up,
Yes,
this
sir.
baby is getting discharged and gone home and comes back at 10 or 14th day of life, and the mother complains that my baby is not gaining adequate weight.
Yes, sir.
So what are all the things you will look for and how will you counsel the mother?
Sir, any sepsis, sir?
Okay.
Yes.
So proper breastfeeding, proper method of breastfeeding.
Yeah, good.
Good attachment and
very good.
Frequent breastfeeding.
Okay. So what are all the signs by which you know, or what things will you elicit from the mother that the baby is getting adequate breastfeeds?
So the baby sleeps for 2-3 hours after every feed.
Very good.
baby is playful.
Okay.
So 6 to 8 times passing of urine.
Very
Okay.
good.
Then like a contralateral breast milk dribbling will be there, sir.
No, in the baby.
Babies.
Baby's adequate
One more
weight
thing.
gain will be there.
Ah, weight is very important. Oh, good. What are the signs of good breast attachment, ma?
So the chin of the baby is touching the base of the breast, and so the nipple and 2/3 of the areola is so in the baby's mouth. Cheeks are full, and so
It's okay. You are
Baby's
you are
mouth
right,
should
ma.
be
You are right.
wide open.
Okay. So mouth wide open, chin touching the breast. Okay. Upper areola
Lower
more
lip
lower
visible
lip
everted.
is averted.
lower lip everted, upper areola more visible than the lower, so that the lip should cover almost most of the areola, including the nipple. Okay, these are the signs of a good attachment. If the mother says the baby is not gaining weight, and if the mother is getting adequate milk, you should check for good attachment, good positioning and attachment in a mother and baby. Okay. Sir, I think it's
So,
time madam should
yes,
take.
sir.
Yes,
Ah.
yes, sir.
Okay.
We can finish it off.
Yes, madam.
We can come, sir. Suresh Khanna, sir.
Yes, madam.
Shall we close down?
No issues, madam. I think
Enough. I
we have
think.
covered almost
Beyond
all the
9:30.
areas.
Any judges, anything, Dr. Sellakumar and others, Dr. Bhuma and another Sellakumar, Teni, Soundarajan and Sudhagar, any points you want to tell or you want to ask questions?
15 minutes.
Sir, no questions,
No,
sir.
sir. No questions,
Selvakumar
sir.
here.
No questions, sir. Very nice. Extraordinary discussion, sir. Thank you, sir.
Sir, Rajendran, sir, thank you for giving the opportunity to
Okay.
participants.